So let's talk a little bit about the tools of intubation. These tools get brought up in test questions often. This is the only reason why I wanted to really bring it up. Please know the rules when it comes to you picking the tools. When it comes to what blade to use, there's no rule to it. It's completely preference. Same thing with handle size. I know that there's a pediatric handle and I know there's an adult handle, but understand you could use the pediatric handle for adults and you can use the adult handle for kids. There's absolutely no rules when you can use a handle. Next, you can't look at somebody and say, that looks like I'm going to be using a Miller on that guy, except for small babies. Okay, very small children, we use Miller blades because of the width of the blade is much thinner than a Macintosh blade. Okay, that's the only reason why on small children, actually there's two reasons. One is the mouth size and the other one is how big their epiglottis is. And I'm going to talk about that here in a second. So let's take a look at this photo here next to me. The first one that we see is the Macintosh blade. Now the Macintosh blade enters from the right side of the patient's mouth, sweeps to the left. Don't forget that. From the right side of the mouth, sweeping to the left. And the only reason why this blade you have to sweep with is because, one, it's a larger blade. I didn't say it's longer. I said it's larger. It's fatter. It takes up more of the space, my visualization inside of the mouth with a Macintosh blade than a Miller blade will. So I need to get that tongue out of the way. Next, we need to push the tip of that blade into what's called the vallecular space or the vallecula. Okay, the vallecular space is just above the epiglottis. It's the space between the epiglottis and the tongue. Epiglottis and the tongue is the vallecular space, and that's where we're placing the Macintosh blade. Please do not forget that. Okay, because the Miller blade does not get used like the Macintosh blade. Let's talk about the Miller blade. On the other side, this way, I can't even see my arm, but all the way on the end is the Miller blade. Now, the Miller blade is a straight blade. Okay, if you have a hard time memorizing which one's which, think Macintosh, Apple. Apples are curved. Miller beer cans are straight. Or you can think of Miller has two L's and L's are straight. However the hell you want to memorize it. Remember, the Miller blade is the straight blade. Now, with the straight blade, we do not have to sweep shit. There's no moving the tongue at all. There's no manipulation of the tongue. There's no need to manipulate the tongue with a Miller blade. All the Miller blade does is you go in and you actually put the tip of the Miller blade on the epiglottis and you physically lift the epiglottis. With the Macintosh blade, you indirectly lift the epiglottis by lifting the vallecula. So again, the only blade that you physically touch the epiglottis is with the Miller blade. You have to know that. Okay, that's just how the tool works. Okay, so that's Mac or Miller. How do we know that we're in the trachea? So how do we know that we're in the trachea? This is something that's extremely important. It gets brought up a lot in test questions. There are several ways. Passing through the vocal cords, Jay calls. Yes, we can pass through the vocal cords. We can visualize passing through those vocal cords. That's a good indicator. But I'm going to tell you what, it's not the best indicator. And the reason why I say that is not all vocal cords look the same. That's a weird thing to say. It's like, dude, how can vocal cords look different? Well, if you've intubated a lot of patients, sometimes it just doesn't look like two pearly white vocal cords that you visually see. Sometimes it's a little bit different. End-tidal capnography is the best way to know that you're in. I'm going to tell you right now, if I'm taking an exam and they ask that question, how do you know that you're in the trachea? And they give me visualize the vocal cords and they give me end-tidal capnography is going to be the answer. Now, they might not give you end-tidal capnography as an answer. If they give me visualizing the vocal cords, I can pick that, right? Because that is a very good one to know. But the standard, yes, end-tidal capnography, and it has to be waveform, because I seen that in a test. That was awesome. The test said colorimetric, and of course, I remember a ton of students jumped on it. Oh, capnography, but it was colorimetric capnography, and not digital waveform capnography. And I remember the answer was wrong. And they're all like, what the hell? It's capnography. Colorimetric capnography is way different than digital waveform capnography. A couple other ways that we know that we're in the trachea. One of them, we can listen to lung sounds, obviously, right? If I listen to lung sounds and I hear lung sounds every single time I squeeze that bag, that's a good confirmation that I'm inside the tube. If I see condensation inside the tube, that's a good confirmation. But understand, you might see some condensation if it's inside the stomach. Now, Mike brings up negative epigastric sounds. That is a standard, especially in textbooks, to always assess for epigastric sounds. Now, I'm going to tell you, real life application, listening to epigastric sounds sucks, right? You could sit there with your stethoscope over the person's belly and you're like, squeeze the bag, right? And the freaking truck is loud. People are talking. It's very challenging sometimes to hear epigastric sounds. I always tell people, real life application with regards to epigastric sounds. Take your hand, put it on the patient's belly, and just tell the person a bag. If your hand lifts up with that BVM, you're in the stomach. Okay. A lot easier than having to listen for it. But yes, listening for negative epigastric sounds is something we need to be looking out for. Now, that gets brought up. What if we are inside the esophagus? What if we're in the esophagus? What do we have to do? And how the hell am I going to know if I'm in the esophagus? Other than, what if the person who's intubating says, I saw it go through the cords, but you're trying to listen to lung sounds, you don't hear anything. The best way to know, throw on the end-tidal capnography again, okay? If the end-tidal capnography, the sensor is cleaned, and you place it on the tube, and you bag, on your waveform capnography, you should see a ventilation, right? You should see a plateau. If you do not see a plateau, and the end-tidal capnography remains at 0, you're not in. What I'd recommend you do is always, but before you pull the tube, always look at that end-tidal capnography. Make sure it's clean. I think there's been 2 times for me personally where there's been like vomit inside of the end-tidal capnography. Clean it out, throw it back on, and then you actually, we are in. Okay. So make sure the equipment's clean before making that decision. Here's another interesting tip when it comes to intubation. And if you accidentally intubate the stomach, hear me out. Inside your mouth, there's only 2 different places that tube can go, either in your stomach or inside of the trachea. If you confirm that you are inside the stomach, push the tube to the side and re-intubate the patient. Don't pull it out. Push the tube to the side, re-intubate your patient, and then just put the next tube in the other hole. Does that make sense? You would be shocked to hear how often people pull tubes, re-intubate, and they intubate the stomach again. It's freaking crazy. Just remember, if you confirm that you are in the stomach, cease bagging the stomach. Okay? You're going to have a lot of problems. I've been there several times where we bag the stomach and you hear that, it's like, oh no. Then all of a sudden, whatever that patient ate yesterday is coming up the tube, pain in the ass, right? We'll get into some deep tracheal suctioning.